Hi, everybody. The big takeaways from this chapter on depressive and bipolar disorders are these. First big takeaway is, it's a couple of things, observations from the anxiety disorders chapter that also apply here in this chapter on depressive and bipolar disorders. First of all, remember that continuum between normal and abnormal? They're on the same continuum as each other. Everyone experiences, like in the anxiety disorders chapter, in this depression chapter, everyone experiences depressed mood or sad, pessimistic days at one time or another. That's absolutely normal. Major depressive disorder is far greater in intensity and duration, usually both. In intensity, it's really, really depressed, and duration, it lasts for a long, long time. Not a few hours, not a few days, but for weeks and often months before a person goes and sees a mental health caregiver. The second thing to remember, related to the anxiety disorders chapter, but also applying here in this chapter, ideally, treatment for depressive and bipolar disorders also comes in two steps. Number one, depressive drug therapy first, and number two, it's followed by talk therapy, also known as psychotherapy or a form of counseling. Remember, we cannot sit and talk to and educate a deeply distressed patient with a mood disorder. So medications will perk up or energize the depressed patient just as they'll settle down and relax the anxious patient so that we can engage in the educational experience that is psychotherapy. In both cases, this drugs first approach allows learning to take place in psychotherapy, and that's really what psychotherapy is all about: education, learning about yourself, what happened to you, and how to prevent this from happening again. Again, just like in the anxiety disorders chapter, as the patient's coping resources improve over time, as they learn new skills, new coping skills in psychotherapy, we plan to decrease the medication until they reach a point where they no longer need it at all. The second big takeaway from this chapter, in this chapter, a new concept to most people is called mania, or the manic person, the manic state. Think of mania as a mirror image of depression. The thoughts, the emotions, the behavior of a manic person are often the direct opposite of a person with a depression diagnosis. So first, thoughts. Thoughts speed up instead of slow down. With a person who is manic, their thoughts speed up instead of slow down. Their emotions, when a person is manic, their emotions intensify instead of deflating. Like in a depressed state. Their behaviors, their movements accelerate. They move really fast. They talk really fast. They seem to be very, very high energy in a manic state instead of decelerating, slow down, like that image of a person with depression that we would think of, that kind of talks slowly and moves slowly. Think of mania as the mirror image of depression. Now, it's a really common question, and it's a very reasonable question to ask. So what's wrong with being so happy? This idea of mania, the opposite of depression. What's wrong with being so happy and optimistic like the manic patient? Take a second and think about this. The problem is that this wild optimism of the manic patient leads a person to take uncharacteristic risks and to engage in impulsive behaviors. Things like getting in your car and street racing, or investing in risky financial decisions, making risky financial investments, or impulsive sex acts, like having sex with a stranger. Because when a person's in this manic state, the wildly optimistic patient only can imagine the positive outcomes, like winning the race or the pleasure. They live only in the moment and for the moment. And as most adults know, that kind of poor judgment is the great danger for a manic patient, to only live in the moment, not think of the consequences, and that's part of what it feels like to be manic. They simply do not think ahead. They do not imagine negative outcomes of any of the activities that please them, and therefore they take what you and I would call risks and inevitably get themselves in trouble. The last big takeaway from this chapter, notice the thoughts or the cognitions of depression. Aaron Beck in this textbook calls them cognitive distortions. In your textbook, cognitive distortions. The thoughts and how these thoughts maintain the depressed mood once it's initiated. In your textbook, they refer to it as ruminations in the research on depression. This negative self-talk is enough really to make anybody sad or pessimistic, and you always witness this when you're interacting with a depressed person. Like Eeyore. Remember Eeyore from the Winnie the Pooh stories? Eeyore, they always see the negative side of things. They're always pessimistic. They always are making the negative observations. So of course they feel depressed. They feel negative. The cognitions maintain the depression once it starts. Cognitive therapy is ultimately what is needed to stop that consistently negative outlook and that self-talk, of course. So in summary, the three big takeaways from this chapter. Number one, everyone experiences depressed mood or sad, pessimistic days at one time or another. Major depressive disorder is far greater in intensity and duration, lasting weeks or months. Second big takeaway, like anxiety disorders, treatment for depressive and bipolar disorders comes in 2 steps. Drug therapy first, followed by talk therapy or psychotherapy. And then secondly, the third, the last takeaway, finally, notice the cognitions of depression maintain the thoughts, maintain the depressed mood. Thoughts drive feelings. Once it's started, the depression, the thoughts maintain that depressed mood. They seem to only see the negative side of things. And again, cognitive therapy is ultimately what is needed to stop that consistently negative outlook and self-talk. Those are the big takeaways from this chapter on depressive and bipolar disorders. Thanks, everybody.